meeting. And welcome to Chris, who is our Acting Director of Finance, and to Adam, who's deputising the virtual rights today as well. And also welcome to John, who is one of our new governors, who's here observing. So nice to have you with us, John. So John, just for clarity, I can't take questions in this forum. If I do a briefing at 5 o'clock, where I can put any questions from governors. All right. We've got quite a lot on the agenda, so we are going to have to move fairly swiftly. We've got quite a few presenters as well, so we need to try to stick to time as we go. Beginning with apologies, got apologies from Paul, from Laura, and Jackie Smith, Laura, Mohammed Subra, and Alta as well. Declarations of interest, we've got a new one noted from Chris. Are there any other declarations that people want to make in the room? Okay, thank you. Minutes of the previous meeting. Is everybody happy that they're accurate?
Sorry, Sarah, I know we're trying to quick. Is there any internet in the room, or is there a problem with the Outlook again? I'm just trying to access my papers.
Right. So I'm on internet, but I'm on a secure one.
There's a way to access Team Engine. Could you access Team Engine? Even without having to Sarah and do that. Sorry to bother you.
Is that all right?
Is that fine?
Is anybody else? Okay, well look, I'll keep progressing and sort it out as we go. So in terms of the minutes of the previous meeting, are people happy that they are accurate? Yeah, okay. And in terms of matters arising, Jackie?
So
basically, right? Yeah.
Yeah, I think there's one, and there's a request from Stroke from the impact. It's circulated paper beforehand. I'm happy to go through it, or just take any questions that I
We'll just take questions. Has anybody got any questions on the paper? No? Okay. Sounds good. Thank you, Ray. And the second one, 024003. That's for providing more detailed update on the cancer incidents of the next.
Yeah, that's well. That's going through quality of cabinet.
Okay. Okay, that's great. So in which case, should we go to Louise?
Yep,
You?
okay. Obviously, there's two reports. I'm not going to go through each report, but I'm going to try and summarise across the both of them to kind of alert you to key things. So there was an alert in May, there was high level risk that the hemanetics, is it the blood hemanetics blood? So one of the kiosks in maternity broken, which meant it couldn't be refixed, and the whole system needs to be replaced with significant cost. 2 additional risks were therefore added into that in July, which was risks associated with getting the wrong blood or blood component to patients or within transfusions. Mitigations were in place, were noted, but I wonder if Ray thinks any update.
So the case has been approved for the being worked through now. The risk of there are 3 risks on there. I can't remember the numbers.
Yeah.
But one of them, the hemanetics, I'm going to stand alone. The other 2, that wrong blooded tube, is going to be combined with the other one. So
Okay.
reduce 3 down to 2.
Okay.
We did have discussions about we reduce down to 1 overall risk. We've got on the 2 different to so works progressing, and the mitigations that were in place found, and so what we're having to use it so for those who are familiar with it, the system that we have has so if the patient requires blood, the blood is in the kiosk, it's detailed scanned, it opens, we normally take out that patient kiosk are under the diet basically. It sounds like, well, why don't you replace the kiosk? We can't, because the new kiosk have different software systems between the so our hands in force. But at the moment, we are basically having to micromanage the might. So it's a bit of a clunky process. It's a safe process. It's not ideal. It takes a little bit more time to get make sure that we do get. So it's going to take a probably it's significant cost and a lot of training.
The current situation now is safe.
Current situation is safe. It's mitigated. It's not sustainable. We are most happy. And cost, etc. It's really not bad.
There's some additional risks that were added to the high risk register in July. They're all in the papers. Time taken to diagnosis for autism is now averaging 42 weeks with risk to long-term development. So not children not diagnosed. The hemoglobinopathy, I think I've got that right, service. There's been an inspection by a non-statutory body, which is logical service society. If you want to say quickly something about that.
Yeah, I can do certainly. So it was a peer review of the inspection. It was carried out by the UK Forum for Hemoglobin Disorders, which is the British Society. We are a local service for hemoglobinopathy, and hemoglobinopathy, I mean sickle cell disease and thalassemia. Leeds are our specialist service, and Sheffield and Manchester by the higher coordination centre. We provide a service really which is in excess of what would be expected for a typical local hemoglobinopathy service. We do have who are affected by the disorders by significant, I think we talk about 80 or 90 patients, relatively high number. The inspection, inspection, the review report has been received. We have checked out we see that has gone back to the UK FHD. We haven't had a comeback. There are various mitigations which we having in place. The most significant concern they raised was around not having a red cell expert, and we wouldn't expect to have a red cell expert to look. These, for example, only have one, not being able to recruit any. But the chances of Brad will be able to recruit one local centre is unrealistic. We can see next week. I'm going to go through that just to give them some context.
Then the third one was the increased risk provision of a consistent stroke service, which we talked about before. Just something I want to pick up that I didn't pick up in the academy rate. So we talked about vacancies and sickness, but also some behavioural and cultural issues that whether it was relevant.
Yeah, I don't think it's much behavioural and cultural. I think it's the approach of people, particularly around the services. I think there's a view that the therapy can only be by trained specialists in whether it's physiotherapy or therapy or and of course that specialist input is really important. also provide therapy and enablement of patients on there in just their everyday care. So I think it's more around the approach to what we mean by therapy, how we can extend the specialist therapy to get into everyday therapy. But I don't think it's so much behaviours and public behaviours. It's all that mindset.
Very much. Patient safety, the final two legacy SIs have now been completed and the learning share. So everything is now on eServe, but those processes and the investigations, how we do that and the reporting is still maturing. Themes, patient safety themes were emerged and considered. Was some improvements identified or improvement needed in relation to duty of candour that Judith just brought in relation to patient death, which wasn't about the investigation itself, but about perhaps improvements in terms of kind of understanding of the duty of candour, not just in its duty, but in terms of its implementation.
Yeah, I'm happy to spend 30 seconds. So, duty of candour, statutory duty of candour is required if the patient suffers moderate harm or above, and it occurs during a regulated activity, and if the event that happened was either unexpected or unintended. I think what we need to do is have a bit more clarity, particularly with our surgical team, that predictable complications, for example, if you have a major vascular operation, not exactly unpredictable, and it's something sensible and explained to the patient and families beforehand, but it's unintended. So if somebody suffers moderate harm or above as a result of that potential bleeding, it's a predictable complication, but it still should be subject to duty of candour because it doesn't. So it's quite a nuance. I'll look at that.
It wasn't a concern, it was a learning improvement issue. So the QPSA dashboard is developing and it's starting to look really good, I think. It's still work in progress with better oversight and insight. So there was in the paper, you'll see identifying pressure ulcers in one of the walls and get clear mitigating actions in place to address that. It felt triangulated with the PSERF work. Shimmy data is improving, but still high. Explained that, talked about that before in terms of it will take a while to do the actions we've put in place to reduce that. Crude mortality is, however, still falling. Maternity, Carly's going to be talking to that. There is some updates of that, but it's just the CQC inspection. On page 5 of the July report, you'll see the key points from the inspection, and the first one is exemplary neonatal service findings. And then there's other staff learning and questions in relation to that. I think it's fair to say, looking at the stillbirth neonatal deaths and the figures that we look at, there's nothing significant need to raise about that. The infection control quarterly report, that's going to be presented here. There was an update on getting it right first time, or GIRFT, and the pancreatic cancer review. What the findings of that could be, but concerns in relation to a risk that we already have 2549, which is about ability to deliver non-surgical oncology services. And I think there's going to be a meeting with Tim Briggs, who's chair of the GIRFT. Do you know that was going to be in May or something?
Yeah, so I met with Tim Briggs, and the discussion was really about, I explained to the context and the challenges around the we've had in oncology. We have a collaborative service with Airedale and the different challenges because we've got staffing. His main ask, and he understood all that, his main ask was to ask us to do what we can to free up funding to attend the pancreatic NDC.
Then finally, just draw attention to page 4 of the May's paper, which is the hospital at night huddle update, and an excellent example of working quality and improvement. So increased confidence in staff, reduced lengths on stays in ICU, identifying deteriorating patients that haven't been identified before. Attention to that. So that's the end of the QPSA reports, but I know that I'm next talking about the safeguarding, but if anybody's got any questions before I launch into that bit.
Yeah, that's great.
All right, thank you. So we had reports from the adult and children safeguarding teams at the last QPSA. It was really detailed reports, the breadth, scope of the work that the teams do, what they cover, specialist skills and knowledge that they have, and approach, very strong. But there are incredible challenges for those teams, and they increase constantly and stretch the specialist resources of those teams. So in relation to adults safeguarding, at the moment, some of the key things are detentions under Section 136 of the Mental Health Act, which is about taking people to a safe place. A&E is considered to be one of those safe places, but it's the very last place where some people who are in mental health crisis need to be. So there's ongoing work with the police about implementing those that process. They've got new in-team members, specialist advisors for domestic and sexual violence, and there's good compliance with safeguarding training across the trust and prevent training. Child, significant challenges, the number of children with poor mental health or in crisis increasing. I guess that's not news to anybody here, unfortunately. Bradford does not have a specialist mental health professional. I'm guessing that's a child psychiatrist or psychologist. I guess we have specialists. It's what type of that is. Don't know if you.
It did seem to use the right. In the child psychiatry, I catch you with.
So you're working across. It's not within. That's very close working relationship.
Yeah. I had a helpful catch up with David ago, I think, and he was talking about the challenges that we could in how psychiatry beds and that natural in terms of 136, there's a 136 please. I understand the 136 which we have the one year Dell, 1 year plus we can move to other something or will be this is the big geographically what.
Thank you. Nearly done. There was raised some problems with systems as ever not speaking to each other. Paper litigations for that and potential risk. But they're working with IT concern and I don't know to say about that, but they're working together on that. But there were some positives, lots of positives actually, lots of the child safeguarding team were the top performers in the national audit. And they are noticing that there's more with the emergency department colleagues this idea of the child behind the adult, so more referral to their services when there are safeguarding concerns with adults. I think that's the main.
Right, thank you. Any questions on safeguarding? They were really comprehensive, of course.
There were,
Yeah,
they're excellent. Whatever question you ask them, they're
they got it.
yeah.
Okay, all right. Well, shall we move on to maternity? Carly there. Hi, Carly.
Seriously.
Sorry, it's first time I've done this to this, so. It's as scary as it was. Oh, that's not. All right, Carly, nice to see you again. Thank you for coming today for some of the slides on holidays. Do you want to take us through your presentation.
Just yeah, while it's loading up, can I just introduce a little bit?
Yeah.
So you'll see there's a comprehensive bundle of documents again. And you remember that in January at board, we said we were going to get a task finish group together, the oversight of maternity and papers, just to see if we can reduce that burden. So the chair and I had a discussion before, and we're going to make ensure that that happens at maternity safety oversight.
Yeah.
What we're going to do.
Yeah.
Which will help. What we are continually trying to do though is the full suite of papers that you have that we're asked to report, but in addition to that, we tried to work a key theme at each board so that there's a more in-depth look at things and just quite salient points. So we'll take the reports as read. Carly's got a few slides to go through, and then I'm going to ask Carly just to do a little bit of an update on the MNSI letter that we've received as well.
Okay, that's great.
Thank you.
So, April and May's current update paper presented the main job following patient safety database I think delegate authority board. Papers received the appendix C recommendations were all accepted. Details regarding stillbirthing and death in HIE have been shared and they're also available to just one part for information. There were 3 club companies sending sides and investigations of including the recommendations and learning representative to the 4 items not yet received by GPSA to report today. The review of the May 2024 all party parliamentary group report on birth trauma and indications from the Bradford. Information regarding formal escalations of concerns, Pam's just mentioned in the slide, which will provide to news and service response. It's the biannual midwifery workbox paper, which is a requirement for 17 year 6, and early escalation to internal. So 3 completed internal investigation report. Available for a board. We are on already progressed. There's 4 points within one of those MNSI reports in which the right context we didn't agree with and provided we can go back to it. And we did make a number of amendments when we sent the draft report, which were changed, but 4 points we wouldn't change and share the report with the panel for the recording with regards to what those 4 points were. And we will meet with the panel if they agree to do so, and we'll sort of go through those points with them, also with that report down any further. Rose to the legal room, and we've got information there, statement, we did have a meeting with MNSI to try and agree with regards to those points. The birth trauma report was published on 13th of May. There was 28 recommendations made, quite a number of them for the government and NHS to press and implement. The recommendations are already included within the delivery plan and the priorities and operational planning guidance for 2024-25. So we're already on quite a number of those recommendations. Big focus on reducing policies. The key risks for us to service in regards to that is in service specifications for the perinatal pelvic health services. Analysis on that document to understand where our risks are and we'll do a risk action. So, escalation concern letter. We had a maternal death in January of a lady who had her antenatal care was transferred to Leeds and stopped and died at Leeds. Principal diagnosis is fatty liver. We're waiting out for postmortem to confirm the cause of death. Regards to that case, he's been led by the MNSI team that for Leeds. It's not a team that we've sort of worked with before. The sent a letter of concern in regards to Muse, which provided a response to, and this was put together and we're still waiting for feedback from that response. We have that, and I don't feel fully assured with the response, and don't feel that work was on them in the workplace is actually working guidance, but some concerns around the system. We are having a meeting on the 30th of July to go through that and try and provide them with some more verbal reassurance. I think the issue is sometimes that when you send written information, you don't always understand the context of always helpful for that meeting to be able to go through the evidence, be able to sort of work through it so they can actually see what we're saying. I'll do that a bit now. So in relation to this case, we also received another letter of concern last week. And this was in regards to consultant attendance when the lady came in to AD. So a formal response has again been written by NARSIA director, and that's been submitted this week. So we're waiting for response from that. The report in relation to that case is in a draft format, but they're unable to share it at the moment because we're waiting for post-mortem results, but have sent learning. And the area of concern there or learning is around handover and SBAR. So again, we've got a meeting joined with AD next week. What I've started to work on another issue. Biannual review for the workforce paper. This is a requirement for Safety Action 5 maternity. From partner meeting. Or appendix of the other action list. No requests in that. But the birth rate push review has been undertaken. We're just waiting kind of. Academy of two internal deaths occurred in June. Really sad. The day was 8 days plus 10. She was known to mental health services. I've been seen really regularly and had quite long from personnel. Sadly took her own life at home. We have had a joint MPT initial meeting with the DCT about some initial learning, and there will be a joint SI with the MNSI criteria. Internal reporting, review, investigation, but we will share that with external partners from the LMS. The second case is an antenatal death of 28 weeks. Postmortem hasn't revealed the cause of death. That's all internal deaths. Each year, averaged about 3 to 4 minutes. When we look at all our cases, it's not anything, they're all very different. We've not recognised any themes, but we will be putting them all together and doing that real deep dive to sort of look at whether there is any themes running through. They are very different, aren't they? Yeah. Karen, thanks. So, thanks, Kelly. I know you were incredibly nervous about coming in person, but you did a good job, and I could just hear you. So, just a bit of context that might be helpful. So, MNSI is the Maternity Newborn Safety Investigation
branch, safety investigation. And I did have to Google that to just check what the new acronym was. And it was previously HSIB. So you've heard us talk about HSIB reports. And they are now under the CQC. So that's where they're now housed. And their job is to independently investigate any significant incident meeting certain criteria. Now, that doesn't necessarily mean that we have done something wrong, but it means an outcome that's not been as expected and gets looked into. They will then go through and speak to people individually. If they have a feeling that there's something that might cause harm again, they will send an immediate letter of concern. But at that point, the full picture has still not been pulled together. So it's a bit like when we declare an SI and we'd say, okay, is there any immediate learning that we need to do? Well, we might need to do this. But actually, when you've done the investigation, it may be something completely different. It may be that, or it may not. So this is what MNSI does, and they are completely independent. And they interview staff members, the ambulance crew, the family, and then bring all those views together. We also do our own internal bit of an investigation as well. So I know that Carly has met with his family on several occasions as well, just to pull that together. And we also review the timeline individually. So we are awaiting the final report, which will also come through to board, which then goes to close board because they have quite patient identifiable information. So that's just a bit of a background. And I think the question that we need Carly to answer, and I know the answer to, is do we need to do anything today because somebody is at risk today? We do not think so. Are there things we could do better? There always are. So there will be things we can do better. We don't think we need to do anything urgently as of today or last week. Do you agree with that?
So normally it takes 6 months to report. That's why they just want to share the learning so we can get on with looking at the improvement. It's not really been very clear whether, without the context of the report, whether this learning would have directly impacted on, made a difference to this learning, but I think potentially the thing that it might do. So there is definitely things to do. It's helpful finding the feedback. Yes, it's fairly feedback.
So I had 2 questions and Karen's answered one of them. One of them was, did we have any concerns? And it sounds like we can learn, but with no real concerns, and the meeting should help talk those things through to kind of reach the data given. The second question was, post-mortem, so the lady died in January. I'm just thinking of the lady's family, and we still don't know the post-mortem. And you just said it's normal for maternal death?
It's things up all over.
Okay. So it's about 10
cases with neonates when the developed condition tested American and all sorts of it's a coroner that they're writing.
I'm just thinking the family waiting for those. It must be. Yeah. Thank you.
Thanks for that. Just want to pick on 4 points that the trustees agreed on there in an FI report. Are you able to elaborate on that? About the side of the evidence and, what the
So with that particular case, there's a big discrepancy between family's view and staff members' view. And the big visit that took place just prior to the baby's admission, the baby were brought in with seizures. If the documentation supported what the midwife point of view, but the family didn't agree that what was documented wasn't actually articulated. And MNSI felt sort of went more with the family's approach to it, even though the documentation said very clear that the midwife had done a risk assessment as baby feeding and the plan with regards to that. So took snapshots of Turner and the documentation that you're saying that the documentation of risk assessment didn't happen, but here's the evidence for it. But there's not take that on board. They didn't feel that documentation was strong enough within this.
Is there a learning for the trust there then? Piece of information captured in the assessment.
So we are doing documentation of it to these learner for all areas to look at learning. It is quite a complex system and has lots of fields in it which need, it's just about reiterating the box. Documentation fundamentally is going to protect you as an applied when these things happen. So we're just trying to reinforce the importance of detailed documentation really, just to strengthen the care that we're providing.
Right, thank you. Any other questions? Like, golly, you smiled. You did brilliantly. Thank you. Thank you so much for coming.
All right, thanks a lot.
All right, thank you. But then we're going to move on. I'll make sure it's in again.
It is, and I think
Yes,
the things outside, see, I've got them all lined up, and you've got to be quick. Thank you.
Morning, everybody. For those who don't know me, I'm Ruth Tolley. I'm the quality lead for the patient experience. I work alongside Catherine Bentley and Stuart Hilden and the rest of the Case Next team, delivering on all things patient experience. So today, the patient engagement strategy and where we are a year on. If you haven't already seen it, I've brought copies. I've also brought a draft of our accessible
sound.
You just sounded better through the maps.
I can carry on talking in a minute. So basically the patient experience engagement strategy goes from 2023 to 2028. And our strap line is that kindness at every step with no decision about you without you. So we're really keen to make sure that there's co-production in all service improvements, and we've been encouraging colleagues to do that along the way. So just a really brief oversight of the teams scheme. We are actually quite small, perfectly formed team that we with the SARC team, we support the patient education and information, feedback, and the virtual learning. And the volunteers work alongside the advocacy side and the patient. So collectively, we make up patient experience. So we looked at a model of feedback that would be easy and accessible to everyone in the sector. Typically, sort of circular thing of active action, listen, understand, active. We just keep going around the circle and make sure that we're doing that and evidence and learning. So I know that you have seen our report. It's got lots of extensive activities in there that we do. Highlights things that we do. So we're engaged with our watch and we do lots of meetings with them and projects. Joined the EDI 2022 program this year, which was a community engagement event. And there were members of the public affairs, service users, and they were for us on the process how we present on patient experience and involvement. And we started high on that. They were assured that we do positive things in patient experience. And the parliamentary ombudsman. With regards to complaints, and we also got the different mechanisms for looking at complaints and compliment. We get service user feedback from diverse representations, so we invite them to pull the public in to join us, and also about an example of that is AED, where people walk around and told us where things don't work well and things that do work well. Feedback. And we do co-production and involvement with this group in particular. So they're people with different needs that are able to come in and tell us what works well for them. We also joined the Voice Forum and listened
And this is to try and get a directory of different services that are available to different people to make sure that we're not replicating projects that are already being done, and to try and streamline things and to ensure that with our students and making sure that they're voice. So that program, that program focuses activating voice creation movement network, which haven't been. We continue our work with and targeting and as we work with membership as well to invite people into this within our target audience for the major. So I have said thank you there, but there are some things that we did recognise at the end of this that we probably should be included on here. One of our recommendations is that we recognise that it's key now to demonstrate our learning from complaints and concerns. We are currently mapping out our complaints process to ensure that it's not streamlined, because at the moment we have two services. We have the central complaints and the operational complaints. We're looking at how we streamline those two services together to work more effectively. And we were able to overcome and revolutionise an archaic system that was paper-based. We've turned it into an electronic system now, which has allowed for complaints to be processed much quicker at the time of the period and out to patients and their representatives quickly. We have recognised that there has been an increase in complaints in Q3 and Q4 of last year, and that is continuing to Q1, but it's something that we will be looking at. We do deep dives that we think that there may be any concerns for any themes and trends. We are always improving, but I think the public are becoming much more savvy about complaints. I think they recognise their right to voice their concerns, and that they recognise their right to. And obviously, we've been through lots of periods of disruption and problems with action. So those were sort of the key recommendations that we've taken from the work that we've been doing in the last year, the feedback that we've been having from patients and service users, and within the organisation. So I hope that was nice and quick and brief, and that you gave everything that you need. But
I love the catchphrase, no decision about you without you. Sometimes it doesn't feel like that in medical settings, does it? So
yeah, I think we saw an example of it recently where one of our teams had applied to the HSJ for an award, and then they realised that they'd actually included service users. So we were able to go back and support them in engaging with that, and now they have got that, and so it will support them with their application. And we're going out, we're speaking to different CSUs, we've been on senior nurse meetings, I'm going to an allied health professionals meeting next week, just to talk about co-production and how we do include service users in the work that we're doing, and that we shouldn't be doing it without having input.
It's just to give a bit of history to new members of the board. So until last year, we had a separate patient experience strategy and a separate engagement strategy across two different director portfolios. So last year, we brought them together under one executive director, which is myself. And just to say, I think bringing the two side by side is really helping. And the work that Ruth has done to get sort of the patient engagement meeting going with different representation from communities, and also the benefit that we're getting from working with the wider Bradford ICB and the Citizens Forum is essential as well, because actually we're making it really hard for ourselves by thinking we have to do everything ourselves. And actually there's a plethora of information out that already exists.
Yeah.
And that's what we're now getting more involved with, and it is definitely helping.
It is. We've been working with Bradford Talking Media as well. They're a group that support people with mental health issues, learning disabilities, neurodiversity, and listening to them and hearing what they've got to say about what stops them from accessing healthcare and how we think that to implement some things that make it easy for people.
Just got into that. So I've been appointed the Listen Champion for the Place Board. So maybe we could just leave that on that.
Yeah, we do attend the listening events, but we don't get.
Sophia.
Thank you for your presentation on the. Just want to understand to what extent do we do this update analysis and all the different things, types of demographics or are there any underrepresented groups that
We haven't noticed any sort of distinct markers within who we the groups of people that we get complaints from, and they fluctuate up and down. There doesn't seem to be a pattern around that. We have friends and family feedback. So everyone that comes into the organisation as they leave, they receive a text message asking them to give feedback about our service. And we are higher than average in receiving feedback back from those. Overwhelmingly positive feedback that we get. We can actually break it down to ward by ward. So the wards and the service managers can go to their training meetings and they can go to their ward to ward meetings and they can present their data. They can actually narrow it down to individual comments to understand. And then that allows positivity to be fed back to the staff and improves morale because we always feel that we get a lot of negative feedback, but actually we get overwhelmingly positive feedback through care opinion, through health watch, and through the friends and family feedback. And it gives us the opportunity to do what you said when you did. So we can put boards on the ward areas, demonstrating to patients the things that they've said to us they want to see changed. We can then evidence how we've done that. And if you walk around the wards, you'll see you've said we did ward on most wards now, and that's as a result of feedback that's come back to complaints and so on. And we get a lot of large numbers.
Yeah, on the click. It was just to say, Ruth, this is exemplar. And I think there's a lot of learning we could take and maybe work together to think about how we could work with our own people here in our organization. So I love the model of feedback and how you're using that. I love some of the ideas about how you work with others. So I just wonder if maybe we could meet and then think about how we might be able to put some of that in place for our own people here.
We're going through a redraft of our digital strategy at the moment. 4 elements. Lots of our systems are very inward facing. It's a big piece that of course we welcome engagement, just talking about patient engagement, the co-production of patient care. And that is how I believe Bradford does need to be in a better position to be able to engage with those groups. Will go a long way to qualities. So, but as I say, that's part of the significant redraft.
I think it's worth sharing that we do share our data out on the internet so people can see our patient stories, they can see the team feedback that we're getting and some of the demographics there. And we're more than happy to share more if we need to. Thank you. All right. Well, thank you for joining us, Ruth. Thank you. Great presentation. Thank you. I'll leave those there in case anybody wants.
Brilliant. Thank you. It's the cheapest tag team, isn't it?
On again.
I am. So you're seeing it here, and you're seeing it's going to present on the report for and the annual IPC report. I will let you see present in his own unique way.
Thank you. You're welcome. And I think nice to meet you. Bye.
Okay, so this is our 6 organisms which are called Mendatio. So 5 bacteria and 1 seed. These organisms are reportable mandatory organisms. 12 months rolling data and the comparison with other trusts in the region. See the graph of political size. Black is Bradford. So you can see the line we are okay, except one second one, which is MFSA bacteria. That's where we feel like we are above the average. And there is COVID and influenza, especially with the winter season. So the left is the COVID cases and the right is influenza. COVID, you can see the peak has global February. So, and then April, so the report is until end of March. So by the end of March, the number is England data. We don't have our own data, especially because we were using the LFTs, not PCR, and it was not recorded. But I include the cases, you can see on the right also the peak, and then going down and the part. Below graph is interesting one. This is the variants that we have COVID in England. So in the UK. So from the start of the pandemic and until March, end of March, you can see the different variants in there. This is percentage, not number. The total percentage of all the variants. So you can see the orange one now. This is the dominant one, J and not one. But again, there's no evidence that this is more fatal or severe disease causing. But obviously, these are the dominant variants now. Apologies, this graph was not right. So this is including the cases. You can see in February was the peak, more than 200 cases in that month. And then April was 15 cases. So the peak February and then. So officially, April was the off-peak season. So this is the comparison and the target as well. So the target, every trust is given a target for the 5 or 6 mandatory organisms. Seeded, we broke even, 39 each. We started very badly, disastrously. We had 9 cases in the first month in April 2023. It was a very nervous time, but we had meetings, we multiple meetings, and we took action and corrective measures. So at the end of the year, we broke even with 39 cases, which was achievement. And also, it's not showing in the graph, but compared to the region, we are positively outliers. That means we are doing okay, but other trusts. E. coli, it was 84 compared to the 76 target. It was the target. MSSA, there's no target, but there were 54 cases. Klebsiella, again, 20 was the target. We had 32 in the year. Pseudomonas less than the target, so not very significant. And MRSA, there's no target, but I put Mrs. A because one of our lead nurses, she doesn't like saying MRSA, so she hates saying this. So I use them Mrs. A. Okay. Now we thought, okay, let's look at our own comparison with the last year rather than comparing with the target. So let's see if we did better because the target moves down every year. So when we compared ourselves with the previous year, we found out that the CDF was 46 and 39 this year. That means we reduced the number. E. coli was the same from 91 to 83. MSSA is the only one where we went up by 6 number. It's not a significant number, but it's higher. And the significant number is Klebsiella. We almost doubled from last year. And then Pseudomonas, Mrs. A, not Mrs. A was. Okay, so we thought, okay, we need to look at these two where we went up compared to the previous year. So I thought, okay, let's look at our wards and units and see if there's any ward or unit or an area, clinical area, which is causing the trouble. We can target that area rather than shooting it down. So this we show that most even, 111. But it was just even, and then so that means the whole perspective in the area. So this was MSSA. Next. And this is Klebsiella, same thing. So nothing. This is our board assurance framework for FPC, and this is voluntary exercise. It's not mandatory, but there are standards based on the health act. So we look at the standards, which are 10 standards, but 54 overall substandards. So the left is the overall, and then each standard. So we are now left with only 2 substandards, which we are partially compliant. The 52 we are completely compliant.
we're just keeping our progress and to make sure that we are trying to that practice. So this internal exercise, as I said, voluntary internal, we don't report it externally. Now, this is equalize, it's really interesting. The equalize, we have seen consistent improvement in the last 6 months. And we believe that that's because of our hydration improvement project. Now, this is regional project again, regional initiative, but interestingly, the hydration doesn't have direct impact on bacteria, but it has indirect impact due to UTIs. So if somebody is dehydrated, the chances of UTI increase, and as the UTI chances increase, then it turns into bacteria, secondary bacteria. So that has taken effect now, and we believe that because of the hydration project. Now, this is our plan, obviously, bacteria induction measures, including both campus. And so there's a comprehensive plan anyway. I'm not going to share the whole plan, but there's a plan that we keep the progress in check and we add some elements or remove some elements as well. The bacteria, every bacteria gets immediate review as well to see if there's any quick learn that we can have. And the triangulation is done monthly, and then we do iris or the effects of whatever you call it, the new bias. We have updated the seabed policy, seabed at center of networks. Hygiene improvement campaign as well. We've just bought 2 devices, some of these devices, which there's a glove block campaign also now, very well going on, which is to remove the gloves when you don't need them. So it is just unnecessary use of gloves. A, cost. B, if you're wearing gloves, you feel sense of security for yourself, but you feel spreading the bugs for others. So we make sure that the gloves are not used when they are not supposed to be used. So that, hydration improvement project, as you mentioned, there's often a body wash, which is given to every single patient who is admitted for first 5 days. That's given to decolonize or reduce the chances of. So again, the audit tool is now. This is the clostridium difficile, of clostridium fuels difficile now. That's the same way with the plan that we take. So the same thing again. We are also trying to buy some golden commodes, not the commode itself, but the little golden commode. So we have infection prevention control week coming up. So we're trying to have that golden commode, and there's a commode audit. So we see whichever ward has the best audit, we give them so they can keep it in the ward and yeah. So we did audit in stewardship as well. So there's the antibiotic pharmacist who is part there. We try to make sure that we close all corners, that it's not just the practice, but the antimicrobial practice. Now, these are the mitigating actions for our best. The 2 actions that I said we are partially compliant. The vast water safety plan is already ready. By this is already done. We are trying to improve our capacity with the negative pressure room for airborne diseases like TB. And we already have one open now. There are 5 rooms available. There are 4 negative pressure rooms, 150 room, which is now good capacity for the TB patient. Again, we are trying to have another antimicrobial pharmacist because it looks like it's really struggling. So that will obviously make improvement in our data collection. Thank you. I have done that.
Brilliant. Thank you. That's thank you, Naseem. Just looking at the comparative information here. So the marginal changes, either positively or negatively, and that one really at the other one, it's been a marked increase. Tell me more about what you think the drivers, what are we doing and can we do to?
Yeah, when we compare the organisms, the 2 gram-positive organisms, they are mostly or mainly related to the practice. They are skin organisms mainly, they get into the bloodstream via the practice, cannulation, central lines, and everything. But the gram-negative ones, unfortunately, Klebsiella and E. coli, they are gut organisms. So they sometimes infiltrate from the gut into the bloodstream and the patient is immunocompromised, severely immunocompromised. So we found that a lot of cases were oncology cases where they were immunocompromised and the Klebsiella gets into. So that was one factor. The other factor is Klebsiella is on the increase in the community. Now it is real problem. Although I was surprised in the beginning when I came, this is universally known that Klebsiella has taken over everything. So Bradford initially we were okay, but now it is taking effect. And some of the cases are called COHA. Now these are COHA, community onset healthcare associated. We are stuck with this because the definition says any patient who's admitted and then is discharged and comes back within 28 days is counted as COHA. And that COHA is counted into the target. Although I've been arguing with the colleagues that this shouldn't be the case because 28 days is a long time and there's a long incubation period. And so maybe it's the community factor as well, which is contained into this. But again, having said all this, we are not keeping silent. We are still trying to improve our practices and everything, the cannulation audits and other factors. And we'll see how it goes. In the 3 months until now, it looks like we are better than last year. But obviously it's important until March. And hopefully this year will be better than that.
Right.
Thanks. That's always great presentation, and I really have to commend you on all the work you did. Just a little bit further on the Klebsiella. So, we've seen an increase if compared to other similar organisations. Klebsiella is going into other organisations, or do you know if other organisations seen similar increase?
Yes, like the first graph that I showed the comparison, you can see we are less than is it possible? Is it with that comparison that you saw there, the membership there's some, let's say other organisms.
Yeah.
Yeah, this you see here. I don't know if you're not reading. No. You read it and we don't. I can read this.
You're looking at the ones where there's like a list of 7 at the top. It's
I
the
think
bottom
it's
of the 7.
the fourth one.
There's-
Some table, yeah.
Fourth or the fifth one. One of those. But the black one is Bedford and the other other trust in the region. So you can see that. We are still below many.
We've seen an increase. We're actually doing performing well.
Yes.
Into community practice rather than. Yes, we've got to keep doing other things.
The fifth slide along, the far right.
Yeah.
Sorry,
Yeah,
Oh,
I
like
didn't memorize them, but
Right.
I thought I could read.
bottom, the far right one, where the darkest colour.
Yeah.
The darkest colour of that.
Yes, so we are, you can see our increase, this side increasing. So, but we are still.
Thank you. Thanks, Nancy. As well as observing, and you've talked about the community onset and how that. So I suppose the question for me is, what are we doing about it? Not in terms of number of cases, which seems to be going up in the community, but what's the knock-on effect within the trust? So what do we have to do in relation to the ever occurring, other than observing it? What's the dangers of cross-contamination to other patients? So what's the next stage on from saying things are going up?
Yeah, so as I said, the action plan and all the elements, but however, regardless of whether the community increase or whatever, we still have to look at the one which are preventable. So we did cannulation audit throughout the trust, and we found some areas where the cannulation is not very good, the practice, implementation, cannula staying more than 4 days and everything. So we are trying to explore that loop. We are trying to focus on the medical side as well. So the junior doctors of the doctors who we want to make sure that they are also competent, trained on documentation and tabulation and everything. That's another part that we want to focus on. So these are the things that regardless of community, we don't want to close our eye that this is just community. So we want to stay improve our practice. It's not just Klebsiella, any bacteria that has we have this.
Right, more questions? That was fabulous presentation. Thank you. Really impressive work.
Thanks for the Karen is our lead and she's all the support we get. Thank you.
Maybe she could get the golden.
We want a picture.
And come to the next meeting.
Thanks, you see.
Thank you.
Thank you. Okay, right, so
So we, excuse me, we met in May at the People Academy, and June's was actually early July. So I did give an update on the May activities in the last 4 meetings. We have it literally the day before, but I'll just give a really brief recap. We did talk about the annual statement of fire safety for 2023 and sorts of assurance on the risks arising from fires and how we manage these safely. There were 5 fires in 23, up from 2 in 22. 4 of them were smoking or lighter related. One of them was a dodgy charger. The trustees work with the fire service on actions to address smoking on the premises because there's a trust-wide smoking ban. But when staff talk to people and ask them to change their behaviour, there's abuse. So there's a task and finish group at the hospital to address this, just to see what else we can do when there is a ban, but people are ignoring that. We also spent a lot of time talking about the equality updates to the RES and DES. So this is the Race Equality Standard and the Disability Equality Standard. We have seen improvements across all of that data, improvements in ethnic minority staff represented across the workforce, up to now 40.5%, so well above target, and an increase in senior leaders to 18.7% as well. Some really good green shoots around ethnic minorities more likely to be appointed from shortlisting, less likely to be in disciplinary processes, and experience bullying, harassment and discrimination as well. But further improvements to make, as always, mainly around representation at senior levels, the people experience of coming to work here, and then around embedded strategy. From a disability perspective, again, lots of improvements in feeling valued, provision of reasonable adjustment and overall engagement, but some further improvements to that people experience, trying to increase the number of declarations we get through as well, and then the recruitment. We also looked at Thrive Hive, so we invited the team to come and talk to us about a brilliant staff-led initiative around creating a greater sense of belonging. And this is a calendar of events that will be linked into the Thrive portal. And it's around just bringing activity on site, but employee-led, so dance, music, sports, fitness, gardening, other hobbies, arts and crafts, just so that we appeal to everyone across the trust, and there's a place for these people to spend some time socially. We also talked about the workforce report as well, which I will come on to. Moving to the academy we had the week before last, we talked about industrial action. The trust had experienced action from the 27th of June to the 2nd of July. 76% of the trust junior doctors participated. That is an increase. So as doctors are becoming more resolute, the public are becoming more immune for the strikes and the messages nudging them not to attend A&E. And on the Monday, which would have been the 1st of July, there was a record 507 attendances at A&E. So thankfully the trust have learned throughout the strikes and is much better at mitigating the effects. So the impact was lower, but we are seeing now people just waning in terms of support
and attending A&E. We invited Mark to come and talk to us about closing the gap. I am really concerned around the people impacts of the programme, as I'm sure many of you are. But it was a really good update, Mark. Thank you. And we talked about how the programme mitigates the impact on people. We talked about the expected reactions to change, the value of listening and understanding, and sharing the values throughout the programme. So the programme is built from a people perspective around the 3 trust core values. So, for example, We Care covers communication and transparency, workload, quality and patient care. We Are One Team then covers engagement and involvement, and morale and valuing people covers training and development, fairness and continuous education. So we took a great amount of assurance out of that Mark's well cited on the risk, and that there was a lot of assurance through the update that we got as well. And we've asked Mark just to attend regularly, just to give us those updates as well. We had a really thorough session around nursing and midwifery. I know the establishment reviews on the agenda, so I won't go into too much detail. But in general, reduction in vacancies, an improvement in recruitment, a reduction in agency use overall, some gaps in healthcare support work roles, and there is a monthly boot camp. We're just not getting people fast enough through the process, although it's much improved. But despite the improvements, the harms data has stayed reasonably consistent. So the focus has now moved from getting bums on seats and people in to getting people with the right skills and developing those skills to make sure we're productive and that we're doing the right thing as well. So the right people, the right skills in the right place. There's been a lot of work done on the international nurses as well. So some listening events took place. Key themes coming out of those are a more cohesive approach to living in the UK and in Bradford. So, for example, people struggling with Yorkshire slang. So we've offered to put a glossary together that might help that. There were other areas raised as well around understanding that what may be taught in their native country isn't taught in the UK and vice versa. So what are we missing? And progression was another theme as well. So there were some really quick actions such as buddies and potential recruitment of a relocation officer that would help, and then there will be longer term actions as well. And I won't go into details on the biannual establishment review because it's on the agenda. But overall, dashboard, I report every month around sickness absence. It's now reduced to 6.36, which is very good, and it continues to fall. And turnover is the lowest in 2 years at 8.99%, and in April 23 it was at 11%. And then we had a really good conversation around the staff survey results, action plan, and again I know it's on the agenda, but very briefly there are 17 areas, 17 actions covering 6 areas, and it's a really simple plan. It's a very good plan, again, in terms of reducing negative experiences, increasing support for managers, reward and recognition, having a voice. And one of the main areas of contention is around healthy food 24/7. So there's a huge focus on that as well.
Clear. No one's got any questions. Excellent. Okay. So on the we've got the workforce report, and you've got anybody having a question? Medical appraisal and revalidation report. Just a couple of points on that, if you don't mind.
Yeah.
Actually, it's a brilliant news story. So of the 514 prescribed connections within the trust, there was a consultant, specialty doctor grades and doctors with temporary or short-term contracts. 498 of them, so 96.89% have completed their appraisal. 16 were approved missed due to absence. So actually, and there were 2 not in process because they've not been in one of them. So actually, an incredible. I have one question. I'm not sure it was a typo, but like 2,200 doctors haven't been here long enough.
No, it's 2.02.
Yeah,
I think it was a
type of, right, okay. That's also, what? Right.
Yeah, and just to add to what Karen said, so we've had no out measure 3 here with 3s and improvement rating, so which is kind of unusual, especially for a neutral stock kind of size. So we're very much in NHS and football today. We need to have a really quite lack of with us in terms of report on a regular basis. So we'll just have to send an email and yes, we're on board. We don't get anyone. And I had a captain with our employee base and I'm in GMC.
Yeah, it really is a good news story. Thank you. Anybody got any other questions? Okay, and then Karen referenced the annual fire safety report. It's interesting reading. Shall we move on to freedom to speak up?
Thank you, Chair. So it does say that people dialing in, but unfortunately they can't for various reasons. So I don't think there is anybody there. No, so I will carry on, Chair. So thank you. So this is the Freedom to Speak Up report that's previously been to people and is quite detailed with a couple of appendix. And I'm just going to pull out some key points if I may. So we have seen a marked increase in Freedom to Speak Up incidences in the last 2 quarters, so quarters 3 and 4. And they are mainly around attitudes, behaviours, bullying. This is the national trend actually, is that you have more bullying, attitudes and behaviours than natural patient safety concerns. We have had a definite step change though in the number of people going through to Freedom to Speak Up. I think that is for good reasons. One being October is always Freedom to Speak Up month. We do a lot of work to promote freedom to speak up during that time. And we've done a lot of work to invest in additional ambassadors for freedom to speak up. And I was just doing a quick tot-up. So around the sort of spread of ambassadors that we have. And I was looking, so the Deputy Guardian is a doctor, a consultant, which I think is really positive. And that means that we do have doctors going to freedom to speak up, which isn't something that happens everywhere. So doctors value this service, and that can be a consultant or a junior. When you then look at the ambassadors, we've got 11 ambassadors at the moment. We did have more than that, we did have some students. They've dropped off for various reasons, not to do with us. But then if you look at those 11 ambassadors, out of the 11, 4 are men. The range in bands in that group is from a band 3 right up to an 8D. So you've got a variety of bands in there. You've also got different staff groups and backgrounds, HPs, dietetics, nursing, midwifery. And then just looking at the BAME representation as well within that. So out of it, 11 ambassadors, 4 are from a global majority. So that again is reasonably representative of where we are. But we want to, ENF is an area that we don't have a lot of representation for freedom to speak up from. Although we do get concerns raised from ENF, but we want to make it more business as usual in that area to really translate. So that's the state. Oh, sorry. I apologise. I'm usually very good at that, so I apologise for that. So it was heartening to see that and just do that bit of analysis. Within the reports as well, and I won't go into the full details, but we've mapped across the freedom to what are classed as the speaking up questions in the staff survey against ethnicity as well, and looked at the trends from this year's report and last year's report. So you'll see there's a number of columns there, and if it's in red, that's showing that there's been a reduction than previously, and if it's green, it's an increase on previously. I'm not sure we've been updated to draw any definite conclusions. What I would say though is I think there are some pockets within that where from sort of September, October, November last year, because of the difficulties we were experiencing as a trust at that time, people were worried about speaking up in general. not free of speak up, but actually raising incidents. But that's not something that's translated. So we've not seen a drop off in the number of incidents. Incidents have been continued to raise, but there was definitely a concern with staff about what will happen if I raise an incident. And we've dealt with that very, very proactively. We've been very open about it and reinforced that we always wanted to speak out. Another couple of things to just pick up on training, please. So there is the 3 elements of the training. I won't name and shame people, but we could do better and lead by example. So if we could all look at that, it is on ESR. You do have to though put in freedom to speak up training, because it will not automatically come through onto the training that you need to do. And that again is being reinforced with all of the staff groups as well. Interestingly, the National Guardian does a different training every year for the Guardians. This next year they're going to be focusing on EDI. This is on the back of some of the national reports that come out. And feedback from that is that it's a 3-hour interactive session, as we said, very, very, very good and well evaluated. So we can look at that maybe as a wider thing to see how we could access that more widely if we wanted. And then the final point to just raise from me is, if we continue to see the current number of concerns being raised continue, and I say the word concerns, it's not a negative thing, it's a positive that people are going to freedom to speak up, then we will need to look at the resource that's associated with that. Stu has 12 hours a week to do this. I know she spends a lot more time than that on it, but we will address it.
I think that's quite significant across the this time.
Yeah.
To, also, when we're going through the change that we're going through and closing the gap, the people will want to speak up about this and about, so we should expect a rise in we should research. The big.
Thanks for that question. Very detailed report, lots of branches. On the nursing midwifery,
Yeah.
is that because we've got more staff in it?
So we would expect.
Are there any themes emerging?
Not necessarily. I mean, they are very general. So the main sort of, I've put there 60 are around, I'd say, behaviours, attitudes, which can result, we know, in instability into a patient safety. There are then a small number that are raised as direct patient concerns that we would investigate. Again, there's no major themes within there. We see it, what we tend to do. It's really hard sometimes if people report anonymously. But I'll give an example. We had a number of concerns raised probably 12 months ago around A&E. And similar concerns have been raised a couple of years before that. Really honestly, they were about poor behaviour and allegations of bullying. We actually sat down and did a big sort of listening event with A&E and commissioned an investigation, even though we didn't have any named person making the accusations. We knew the accusation were being made about certain individuals, and that went through a trust disciplinary process, and there was an outcome at the end of that, which was then obvious to the staff in that area, and they felt assured that they'd been listened to and that actually been taken. And it's really hard when you get that anonymous stuff. You can't always put it down. So when we see those big things, there's we'll just talk about this yesterday, weren't we, Chair? So we've seen a couple of concerns coming from radiology as well, just how politics type issues. So I'm going to do a listening exercise with Sue and the team down there just to try and pick that a little bit more as well. And we find that those listening exercises are really quite effective.
And so Julie and I met with the frequent speaker garden yesterday, and what was impressive to both of us was that actually most of the time the organisation was aware of the issue and was already working on it, but as you say, it might not be visible to people, so they still feel the need to speak up, but it, you know, it's great that it's in awareness as well.
Just on that point, it's really important. So it is really hard to feed back to people sometimes, you know, because sometimes the outcomes are very private and personal to an individual, and we cannot always share the findings in full. And I think people are frustrated with that sometimes.
So we've got Louise and June.
Thanks, Karen. So I failed to bring my laptop today, so I'm going to rely on visual memory, which may not be very good. So I'm thinking now in my mind, I'm seeing those appendices, which are the red and the green. And you did explain what it is, but can you tell me what the red and the green are again?
The change from the previous year.
So is the green a more positive score?
Yes.
And the red is
Yes.
a negative score. Okay.
No. So the first column is the actual score from the staff survey. The red and the green is then the comparison with the year before. So if it's red, it means that the score has gone down for that particular staff group. If it's green, it means percentage-wise it's gone up. The bits of information that's missing on there to triangulate is what's happening nationally.
Yeah.
Because nationally you see swings as well in those staff groups and by those bands.
So a score going up is good, isn't it? Because it's like saying people have got more confidence, they're happy to report, etc. So there were some groups that were all red, some that were all green. So Safia mentioned the maternity services, that was all green. I thought that's really positive. And then there were some other groups, and I can't remember what they were. I think some of them might be psychologists. That's why it stuck in my mind that were all red.
Yeah.
So, but there's no, can't see. Thank you. But there's not numbers of staff in each group unless there is in there. So I just would. So those people that are red, some of the numbers were really significant changes.
Yeah.
But how significant is it in terms of workforce, and what is there a focus on those groups?
Yeah. So what Sue is now doing with constituents is using that information to focus the work on going forward. This is the first time we've seen it in this way. The first time we've had the work from the people promise. The bit that's missing, and I think would be interesting to see on a graph, is what's happening nationally with these same things, because what we see is the questions nationally move up and down as well, depending on the mood music and things that are happening. We have included anybody with over 10 respondents in a group. So we might be talking about 11 people, 12 people, we might be talking nurses, 1,000 people. So we need that additional information. High level metrics though are. We are still a good performing organisation in terms of the staff survey questions for speaking out. Although we've come down in one of them, nationally we've come down as well. The individual staff groups and the nuances is the next bit of work for us to understand. That makes sense.
It does make sense. And I also wondered, so there was groups that we've obviously that have had a lot of either scrutiny or focus that actually did really well. So the maternity services and also pharmacy. And I thought, is that partly a result of because of that focus and support within those? Is there any correlation, or is that just me making spurious kind of?
So we put a lot of effort into the clinical staff in maternity and neonatal unit last year when things were in the national press. I went up, Mel went over, a number of us met the staff, gave them reassurance. And I think that has helped in that.
Yeah.
Where I'm seeing one of the other areas that is red, I think there's more senior manager type groups. I think there is some concerns and some grumblings, and Ray and I have heard it, haven't we? Well, why would you speak up? Because this is what happens, or why would you report something? People have got that worry, but we do not think it's come to fruition, because we can still see that people are raising concerns. And I always say we have about 100, 150 incidents raised a week of varying degrees. So it's not just freedom to speak up where people raise concerns, there are other avenues as well.
You want to come in on that? Yeah, I do. Yeah.
I mean, it's important to understand the difference between the red and green. If you look at nurse managers, that column is in green. Is red. Your eyes are drawn to red, but if you actually look at people who are saying, I feel safe raising concerns, it's 90%. So 90% of the nurse manager group are really confident. That's a really good score. Just to go down by 2 points.
Yeah.
So our eyes get drawn to it. But clearly, any deterioration is not where we want to be, because we want it to keep improving year on year.
And I wonder, therefore, think about presentation of the statistics, everything we're doing around that, whether that red and green actually, because that's what it draws your attention.
Yeah.
That's helpful. But anyway, thank you.
Julie.
I was going to add what you had, Sarah. It was good to see the kind of when there were pockets or themes occurring that actually the exec team were aware of them already. And Freedom to Speak Up was just another way of raising concerns. And there was some links to HR work, and Sue seemed to be doing some great work across. So it was my first quarterly meeting as Freedom to Speak Up NED champion, but to be involved in. And the other thing I was just going to reinforce was Karen's message: do training. You know, as a board, we don't look good. So I've only done 2 of my 3. I've got 1 still to do. I did have trouble accessing it, but once I got to it, it's relatively easy to do. So, you know, we need to be better as a board at giving our values to trust, getting that training done.
Definitely. Okay, thank you. Right, that's brilliant. Now moving on, it gives the candle for show today. We've got the establishment review.
Okay, thank you very much. So, just by history and background, we've got new board members. So this is a requirement of myself as chief nurse to look at a midwifery and staffing review on a 6-monthly basis. And that's what we do. We've got a tried and tested methodology for this, which is in line with the national methodology. So we don't just go, oh, I think you need 3 nurses on the board, but there's stuff behind it. So how do we do that? So we use our professional judgment. So we speak to the staff involved. We speak to the leaders in those ward areas as well. We look at the data that we have, including harms, falls, red flags. We look at our bill rates, and we have a tool to measure the acuity of patients in inpatient areas as well. And we can match staffing levels against acuity, and it will come up with a bit of a figure of what the acuity is telling us that we need. We then put all of that data together, and I meet with the individual senior leaders to pull that into one place. And got you the presentation there, and I'll take you through some of it. I don't think I need to go through all the slides. I know it was discussed in detail, but there's some key headlines in there. So, first of all, I'm really pleased to report there's a graph in there that shows that our fill rate for registrants has increased significantly over the last 12 months, and that's really positive. And when you speak to staff and when you walk around, and when I look at the noise that I get on the matron's WhatsApp group, it is much less now than it was 6 months ago, 4 months ago. And that's because of the significant investment we've put into recruitment and the vacancy position that we've had. And if you look at our people metrics, you'll see that our agency usage has dropped. Our bank usage has increased in a positive way to a positive fill rate. Our sickness absence has come down for nursing and midwifery, and also that vacancy has come down, and the turnover rate has stabilised to what it was before the pandemic. Next slide, please. I've got the slides now, on. Next slide, please. So, a few more principles that we have. So, every ward has a band 7 ward manager or a senior assistant in old money, and we say that any ward leader or manager needs at least half of their time supervisory to run the ward. At times when staffing has been problematic, they have not always got that time. We are seeing that they are beginning to get that time again, and we're seeing actually improvements in other areas on the back of that. Now, whether that be complaints, the friends and family tests, improving infections or falls, etc., are all on a positive trajectory. We then put a degree of headroom in because sadly nurses need annual leave and sometimes they're poorly, and we also need to give them study leave. And it's slightly more for maternity because of the additional requirements in that. So we put headroom in for that too. And we have what we call our confirm and challenge meeting, and we've really ramped these up in recent months to really push back and make sure we've got the right staff in the right place at the right time. It has been made easier because the recruitment position is much improved. Next slide, please. So I've just talked about the red flags. So that's we have an electronic rostering system that enables staff to put in and also to report either via a red flag on that system that staffing was not what it was meant to be. But staff also use our IRIS system or our incident reporting system as well. Next slide, please. So that's the nursing fill rate I was telling you about, and that is really positive. So if you think, 6 months ago, we were looking at a 75% fill rate for registered nurses across the board. That is now up to 90%. So that's huge positives. Next slide, please. This is about the principles that I was describing before. Next slide, please. This is a little bit more about the Safer Nursing Care tool. You'll see the fourth bullet point there is Emergency Department Safer Nursing Care tool. That is a later addition too, and we're going to be using that tool to look at the modelling of the departments and the emergency department going forward. Interestingly, so there is a belief that ED is a lot busier than it was. And when you look at the real figures, I mean, we're quite surprised. I think it was about 6%, 6% more people coming to A&E than before the pandemic. But the difference is people are spending longer in the department. So the number of people in the departments at any one time feels a lot more. Because, and people are saying, oh, we need more staff because of that. And my pushback is, actually, do we need more staff or do we need to manage the length of time that people are spending in the departments and move quicker? And that is a focus that Saj and I have got, and Ray, but also as part of the EDCSU, looking at the closing the gap. That's really important if we can manage that, better. Next slide, please. So this is where we have seen that we need to potentially make some changes to the establishment. So first of all, is the acute dialysis unit. We know that in this area, we are seeing increasing numbers of people, and there was a request for an additional band 6 or a post to be uplifted for band 6s, because on ward areas we have a rule of at least 1 band 7 and 2 band 6s. So we pushed back and said we're not going to change that because there is a band 7 there. They do have some leadership time, and it is different from a ward. It's not a ward. It's not a 24/7 service. So we turned that down. Next slide, please. Ward 23. So Ward 23 is our respiratory ward. It has over the winter period, and we saw it actually in Usain's flu numbers over the winter period. Respiratory disease and the burden of that is high, and the staff on there have had a very difficult time. They've asked for some additional healthcare assistance on there. We've said that we need to look at the seasonal variation of that because we think that is around increased high dependency patients in the winter as opposed to the full year of that. So what we're doing now is we're going to look from an annualised hours point of view to say, actually, you might need 6 more healthcare assistants, but is that just for 3 months of the year? So therefore you only need 1 or 2. Again, we're doing, there's been some concerns around care and leadership on Ward 23. We had a policy summit. The staff met with me and we were talking through action that can be taken. And we have been actually changed in behaviours in that area. Staff are feeling more assured. Staff, it is a better established place. So we just need to keep monitoring, but we don't believe we need to put additional staff in at this moment in time. We think it's a combination of lots of things, of seasonal variation and leadership. Next slide, please. Ward 27. So we're going to have this one because this is the one that's saying that we actually need less registrant to just tweak a bit and look at a more reliance on rehab support workers and senior HCAs. That's because Ward 27 is our medical fit discharge area. So the patients in this area should be patients that could be cared for at home or in a nursing home or with a package of care. They shouldn't require registered nurses all the time to do stuff, and they shouldn't be deteriorating. They shouldn't be doing their observations every 4 hours. They shouldn't be being seen by a doctor on a ward round every day. We're just making that step change now. I went on there yesterday and the staff were all happy and smiling and getting lots of things done. And they were saying, oh, it's great, we're moving patients on. So we're actually going to change the skill mix, which is going to result in a £30,000 saving. Next slide, please. Ward 28. So again, Ward 28, we know that this is our orthopaedic ward. So a lot of falls or fractured femurs that we have in the organisation. So the model should be, so usually if an elderly person falls and breaks their hip, it is usually a medical reason that they fell that's led to then a mechanical injury. The best practice for fractured hips is to look after them on a care of the elderly ward. Because of a lot of the acuity that we have had and the demand, again, on care of the elderly or the winter months, has meant that the patients have kind of defaulted toward 28 the orthopaedic ward. That's still all right, but it's not the best practice that you'd want. And then in addition, we know that we have other people that fall and might break a shoulder or an arm that get cared for in that area. And the burden on staff is really hard. What we've noticed is that so there's been a request for an extra healthcare assistant, but we know that they've got a vacancy within healthcare assistants at the moment, and they're using some bank or it might not be always filled. So what we've said is, let's get you substantively recruited to all of those posts. And when you've done that, and we can look at the quality and the leadership on there as well, will that make a difference? So do you need more people or do you just need the right people with the right training? So again, that's the pushback there. Next slide, please. AMU Ward 1, again, so both AMU Ward 1 and AMU Ward 4 have asked for additional staff. Again, we're just going to keep monitoring that and looking at the need for enhanced care. So some of the patients that are staying longer than they should be on AMU. So really, you shouldn't be on an AMU longer than 24 hours. We know that sometimes we have patients on the 3 or 4 days because of downstream bed availability. So there is a request for extra HCAs. We've pushed that back as well at the moment. We're just going to look a bit more into that and keep monitoring the red flag data. Next slide, please. So this is AMU4. So again, AMU4 has some surge beds on them, 3 additional surge beds. I don't think they've been surge beds for about 2 years. They're almost within the establishment. So there is an option to either close the beds and just use them as surge or to staff them appropriately, plus the additional HCAs, which was similar to the Ward 1. So again, we're saying no, not at this time. We need to keep looking at that red flag data, but we also need to work with the operational teams and the bed managers, site teams, to look at bringing those surge beds down, because, you know, Stadge and I don't want to get to winter and have all our surge beds open still, do we? Because we want someone to go. Next slide, please. So Ward 6, again, is another area. So we've now got Ward 6 stroke unit, and we also have Ward 9, which is opened as a rehabilitation stroke unit, and that's really working well. What I would say though is that Ward 6 is meant to be staffed and open to 27 beds, and one of the beds we've been using as therapy. More often than not, there is an increase to 33 beds in that area. To staff that appropriately, that 6 extra beds is round about £500,000. Again, at this moment in time, and because of where the finances are, we need to proactively manage the red flags and keep an eye on our harms data and not staff those beds at the moment and try and concentrate on not surging into those beds. What is positive though, and is that if we do surge into those beds, because our overall vacancies are less, that does mean that we've got better flexibility to staff and help out. The other bit of this puzzle is, so we have this staffing wheel that's live and electronic and linked to our rostering. So we can see in the site team 24/7 where the sickest patients are and where the most demand is. And that enables us to move staffing in a safe way as well. I know from my own experience, you can be on a 20-bedded ward, you can have 10 staff on it with the worst shift in the world because lots of things happen, or you could have 3 staff on and it'll be a lovely shift because absolutely not a lot is happening up there. It can vary. We've got the tools to look at that. Next slide, please. Emergency department, I've touched on this. So no changes at the moment, but we are going to really have to have a deep dive and a look into it. But I do believe that we need to work to reduce the time in the department because that's best for our patients too. Next slide, please. Children's staffing, no changes in this area at the moment. Some bits of skill mixing in the neonatal unit, but we can do that from within what we've got. Next slide, please. So this was a specific request and it was in last year's, and we're going to turn it down again. So Westbourne Green and Westwood Park are standalone sites on their own, 24/7. There was a request to make the ward managers fully supernumerary from the 0.5, and we've said no, not at this time because we can't afford it. The rationale for that was that if you are a standalone site and there's some sickness, if you've got a supernumerary ward band 7, they can go into the numbers quicker and help and support that. Next slide, please. So a couple of business cases that need to be developed. So we always say this is out of scope from the actual security staffing review. So there's the emergency department that talks about, there's ENT and ophthalmology on the back of increased activity, complexity and work that's ongoing there. There's the endoscopy units, or the new endoscopy units that's planned for next year. We need to understand what the staffing impact of that is. We think it's around about 12 staff nurses at this moment in time. And then from a critical care point of view, the critical care network has suggested that the uplift, so the bit that allows for holidays and training, should be 35% for intensive care. We currently have 21.5%. This stance hasn't been adopted by across West Yorkshire by Acute Trust, and at this moment in time, it's neither affordable nor practical because there just aren't that many intensive care nurses out there either. Next slide, please. Maternity staffing. So again, the report, Carly mentioned this report again. The plan was, because we've got quite a robust year-on-year staffing plan around that's based on continuity of care and the RCM mandate as well. We were hoping and planning this year, and it was within the budget, to bring in a midwifery consultant with an EDI focus or a public health focus. We're going to hold back on that until we know that the financial position is more stable, but that is something that we would aspire to do. Next slide, please. So in summary, given a different climate, I would probably be saying, please could I have X number of amounts of hundreds of thousands of pounds. I think the tact we've taken with this is that we recognise the national and the local position with finance, and we have put additional safeguards in place to make sure where we have identified or where people are saying we need more staff, that we can pick up and ensure that we're not impacting on patient safety. And this is the first time we've done it in this way, and it has led to some very difficult and uncomfortable conversations, but actually at this moment in time, probably right conversations. So overall, 30%, sorry, 30%, £30,000 cost reduction. Thank you. Any questions?
Well, thanks, Karen. That was really detailed, but it was really important that our wider public understand the rationale that you had in taking those very well. The key thing is what we said at the end, that patients are still the same.
Yeah, absolutely.
That's what we need to keep strong on. Thank you. Thanks a lot, Karen. Just to stress that we're kind of looking down the nursing line. I wanted to highlight one area in particular, whilst we're not approving additional investment. Earlier this week, we did approve significant in medical staffing in the emergency department. The ultimate rationale for that is to provide consultant residents provide overnight, decompress those numbers of patients in the department, which has then the knock-on effect for nursing. So try and get patients out. What we've observed, we've commented on previously at Sarah during the junior doctor strike, the greater the seniority of the medical input, at peak times, the greater turnover of patients through really rapid and decisive decision making, in order to either move patients into inpatient bed or to discharge them home. So we are saving money in one area, but that's not necessarily the full picture.
I think, and it's kind of good to see that slide at the end, because the kind of link to the closing the gap. Yeah, it almost feels important that we capture that number, because what we're doing is we're saying instead of investing that total number of all those kind of assets at the end, we're going to try to do things differently to not impacting patient safety. So we just feel important that we capture the overall number.
Yeah.
Just as a point of view of this is what we're doing to save that, almost not count as a cash releasing saving, but capture it. And I think it really brings home the impact on our people and the kind of importance of looking at closing the gap at People Academy as well, because you start to see people are asking for things that people really, they want to do it to improve their services, and we're saying no. And that impact on people is going to become more and more marked. So I think it just reinforces the importance of talking about People Academy as well.
And that's why we need to really understand that what this will allow us to do is to maintain safety. That's right. So when I get a ward and there's complaints about not answering the buzzer on time, or I didn't get that jug of water when I wanted it, or nobody had time to talk to my relatives, the more experienced element of things, that's when we probably see the impact, and we just need to be aware of that, because what we can't do is berate people, hold people to account for something when we've actually said we're not going to give you all the tools that you need at this moment in time, because we can't.
And that would feel hard for people doing the job, recognising that.
And it must, but I think there's a BAU kind of nature to some of these conversations from now on. So getting used to having these conversations and actually talking about what we will or are spending money on and not spending money on, and actually the impact of that. So we chose not to do this in this ward, and actually the impacts were negligible, or it actually was positive. And I think it's a great storytelling kind of thing for your programme, Mark, in terms of closing the gap, to be able to share where we're making decisions about spend and no spend, the impacts it has. And actually, this just becomes normal, because it should become normal, because it's about sustainable services and, the trust future and all the rest of it. So I think there's some positive news you can share out of some of these, and there's some honest news you may want to share as well. But I just think it's where's the good practice? How do you make your managers comfortable with delivering some of these conversations, and actually just being really open and transparent about what decisions you're making and not making, and kind of fun.
Yeah, well, and just to add to that, I think the thoroughness of the review that we've done also lends us to think about transformation. See what people see in front of them sometimes, and the demands and the pressure on their time. Sometimes people's immediate reaction is, well, I just need more staff to do the, actually what this is done. And start to think about some opportunities in the organisation to change how the organisation works as well. So it's driving people actually to think about things differently.
Thank you. That's great. Really good piece of work. Okay. I think what I'd ask is, if you start to see an impact, you come back and brief us. So then you do the next review in 6 months' time.
Should we do a monthly report to people? Also looks at red flags, stopping and fill rates.
Right.
So
So
you can
anything
pick up quickly there.
Yeah. Thank you. Okay, I'm going to move this on, and it's running.
So I'll have Kat Shutt, who's our head of OD. She's going to come in and walk us through, but it's just to introduce. I'm so proud to be able to share our final staff survey action. It is the first time that we've really done some overarching, really wide engagement. So we had over 300 people that wanted to join our staff survey action forum to help us to think about actions that are going to help us to implement actions as well. We've had all of our networks. He's like, don't steal my thunder. Yeah. We've had our trade unions, we've had our exec colleagues, and a number of team members just across the organization that have helped us to build this. And it's a live document. So it's not something that we're taking today and then we're saying that this is it. People will still continue to engage and will add to it and help that grow. But I'll let Kat do a little bit of introduction about what this shows, where we're going to focus, and why we've linked it to some of the things that we have.
Thanks, Renee. So hi, everyone. I don't think I've met everybody. My name's Kat. I'm head of organisational development, recently back from maternity leave. So nice to meet you all, and thanks for having me this morning. As Renee mentioned, I'm here to share with you the final staff survey action plan. And as Renee mentioned, we've been through various different groups, our staff engagement networks, our staff networks, trade unions, our people academy, and our exec management team as well. So they've all helped shape the action plan to what it is today. And we've tried to really focus on getting some of the basics right. The colleagues will remember the staff survey results this year. We improved in every area, under every element of the people promise. And we're above average as well, the national average in every area. But that doesn't mean that there's not more work to do. So we've tried to focus on getting some of our basics right, but also focus on some of the specifics that colleagues mentioned. I'm not going to go through the action plan line by line in the interest of time, but just to give an example of that, healthy eating is one that we have really focused on in the plan. And that's not just looking at healthy eating with our food providers, it's looking at out of hours for our night workers and really trying to get that right. That's a really specific one. Equally, we want to get our basics right. For example, with our managers, we want to make it really explicit what a BTHM team manager is expected to do and help them do that. So we want to support managers and really focus on them, for example, as well as teams this year. As I say, I won't go through it line by line, but I'm more than happy to take any comments or questions.
Okay, great. It's a really good plan, actually. It's not over complex.
No,
it's just kind of getting to the heart of the issues. So I really like it. So I don't know if anybody, colleagues, have got any questions or comments.
I think it's wonderful.
Yeah. So, I mean, how are we going to track and keep up to date on?
Yeah, so we report quarterly to People Academy. So I guess through Karen's report, we can keep you updated on progress. Or of course, happy to bring anything back here.
Yeah. Okay. Well, when you get to a significant moment, a significant win, what can you tell us about that?
I'd love to.
All right.
Brilliant.
Okay.
Thank you for having me.
Thanks.
Thanks, guys.
Thanks again. And then, well, this will be really good, because of the cycle of meetings. We haven't had a meeting since we last. The next meeting is next 15.
So,
Okay, all right, that's great. So in which case, we are running 15 minutes late. And we have a break. So can we make it a 10-minute break? Is that okay? Back on the table, 11:30. Thank you.